Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome back to another Power Pack session of AMCI CPT Guideline Mastery Series. How are you all doing? Let me have a quick look at the chat. Happy Friday. Happy Friday, Patty. I can see my team already in the chat. Hi, Miss Mills. Welcome. Hi, Miss Catherine. Okay, hi, Letty. Who else are there? Hi, Kocho. Okay. Uh, okay, type in the chat. Coders. Thank you, Miss Mills, for letting me know. Okay, I will shout out everyone. Okay, hi, Sherry. Okay, so welcome back, coders, once again. Another Friday, another series of another session of the CPT Mastery Guideline series. I hope you all are doing great, feeling energized, motivated, and ready to sharpen those coding skills once again today. Okay, thank you, Miss Catherine, for letting me know. So, here at AMCI, we don't just go through the guidelines, we break them down, we simplify them, and we make it in a form that you'll understand the logic behind it because confident coders don't just memorize, they master the concept. Okay, so we are here to master a few concepts or guidelines from musculoskeletal chapter today. Before that, let me read out the copyright CPT copyright 2026 American Medical Association. All right reserved. CPC is a registered trademark of AAPC, and the AAPC content found within this presentation is a copyright of AAPC. The keyword concept, FTR churn AMC IFAB 7, AMCI ICD 10, flip tap, and MCG are trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. So before we begin, once again, a quick reminder requesting you all to take a moment and fill out the survey form and let us know how you feel about these sessions. Okay, so as always, we have a good participation, good number of participation in the chat as well during these sessions. But please do make sure you fill out that survey form and let us know. Let us know how we did, and let us know which session you want in the future. I did so. Someone did mention out that they were looking forward to the modifiers, and I hope you were there in the modifier session last day with Mrs. J. So we are having a modifier series going on. So we have already completed the week one yesterday. The playbacks are available in our YouTube channel as well. Please do go ahead and have a look into those if you are looking at the modifier session. All right. So we will also continue this series for a couple more weeks. All right. So make sure coders fill out the survey form. And yes, so the topic which we are going to review today is spine procedure coding, spine surgery coding. And specifically, you know, you can find these codes under the musculoskeletal chapter. And the procedure which we will be reviewing is arthrodesis. Sorry, arthrodesis, spine instrumentation, and the grafting procedures. Okay, so these are the topics which we are going to review today. All right, so before we start talking about the different spine procedures, let's first take a quick look at the anatomy of the spine. All right, because understanding the anatomy will make it much more easier to understand the procedure what we are going to discuss. As simple as that. So let me ask you a question. You can type the answers in the chat, by the way. How many bones do make up the human spine? So you can give your best answers in the chat. So I will just wait for a couple more seconds. How many bones make up the human spine? What do you think? The human spine, not entire human body, the spine. Okay, I see everyone putting 206. You might be considering the entire human body. Specifically, I'm asking about the human spine. Okay. All right, you can place answers in the chat. Meanwhile, I will start continue what I've been saying. So, okay, great. So, human vertebral column or the spine actually is made up of a series of bone, and we call them vertebrae, right? These vertebrae are divided into five different regions. You can see the illustration which I have shown in the screen. So they are divided into five different regions. So let's go through one, through them one by one. All right. So first you have the cervical spine, and this is located in the neck. It consists of seven vertebrae. Then we have thoracic spine, which is located in the upper and mid back. And thoracic spine total consists of 12 vertebrae. It is followed by the lumbar spine, and that is located in the lower back and it consists of five vertebrae. All right. Then is the fourth one, that is a sacral spine. Actually, it consists of five fused vertebrae that form a single sacrum. So if you can calculate in the both way. You can consider it as a five fused, five individual sacrum, but it's actually a fused vertebrae, the sacral part. Same goes with the coccygeal spine. It consists of four fused vertebrae, and that forms your coccyx. Commonly, we call them the tailbone. So let's talk about one more important thing. Okay, so great answers, by the way, in the chat. Wonderful participation. Okay, so let me just move on to the next. Yes. Okay, now the thing which I'm going to say is very, very important. So I want everyone to understand this concept well, because this is going to be the base of what we are going to code. All right. So I'm going to talk about two terms that is frequently you will see them in the spinal operative reports, spine surgery operative reports, and in the CPT coding as well. So the terms are vertebral segment and vertebral interspace. So these terms may sound similar, but they refer to two completely different anatomic structures. And understanding the difference is critical for accurate coding of the spinal procedure. So let's start with the vertebral segment. All right, you can see I've highlighted the vertebral segment here. A vertebral segment refers to a single complete vertebral bone. So this is the bony part of your spine, and the vertebral segment includes entire vertebra along with its associated structures. In the below you can see over here, along with the associated structures like the lamina, the pedicel, the transverse process, spinous process, superior and inferior articular process, etc. So that is what you call the vertebral segment, okay, the bony part. Next is the vertebral interspace. So a vertebral interspace is a space between two adjacent vertebral body. So for example, here you can see in this image between L1 over here and L2. So L2 is called the L1 L2 interspace. Is that clear, coders? So this space is not just the empty space. It contains several important structures, like it has your disc. Okay, it has your disc and the nucleus, the annulus. So there are several structures in the vertebral interspace as well. So please let me know. Are we good so far? The difference between the vertebral interspace and the vertebral segment? Type in the chat, coders. As I said, this is very important to know. Type in the chat. Okay. And before we move on, again, let's do a small exercise, and let's test our understanding on this vertebral segment and vertebral interspace. Great. Thank you for letting me know. Okay. So let me know in the chat, how many segments are there from L1 and or from L1 to L5, how many segments are there? Let me know in the chat. Vertebral segments. So segments are the bony part. Okay, I will just wait for a couple more seconds because yes, I think my side it's a bit slow. So I will wait for you all to please answers. All right, great participation. Wonderful. Yes, the answer is five segment, right? From L1 to L5, you have L1, L2, L3, L4, and L5, the bony parts. So you have five segments. Fantastic answers, Goddess. Now, let me know how many interspace are there from L1 to L5. Remember the space between that carries your disc? Interspace. Okay, I'll wait for a couple more seconds. Great. Fantastic. Fantastic answers. Yes, there are four interspace right from L1 to L5. There are only four discs. You can just calculate just count the disc and you will get an idea. Excellent. Wonderful answers. Okay, so I think we are good with what a segment is, vertebral segment is, what a vertebral disc is, or interspace is. So now let's talk about the arthrodesis. So the first topic which we are going to talk is arthrodesis. Then we will move on to the spinal instrumentation, followed by the grafting procedure. Okay, in between we will do some exercise similar to this as well. So arthrodesis is also known as joint fusion, and this is a surgical procedure in which two or more bones are permanently joined together, and this is done actually to eliminate the movement between them. So the primary goal here is to reduce the pain and restore the stability as well as improve the function. Okay, so we will come back to the details of arthrodesis in a moment. But before that, let's discuss why a patient might need the spinal procedures in the first place. So think about it like what happens when the structures of the spine become damaged or unstable. Like you can see the examples, I have listed a few examples like fractured or broken vertebrae. You can see how the patient is feeling when having the fractured bone. Next example, herniated disc, we call them slip disc otherwise, or degenerative disc disease. See, so when these conditions occur, they can place a significant pressure on the spinal cord or on the nerve root that exit from the spine. And as a result, patient may experience symptoms such as low back pain, neck pain, numbness, tingling, etc. So there will be a severe pressure on these nerves exiting from these areas, right? So the question is, how do the surgeon relieve the pressure and stabilize the spine? And depending upon the patient's condition, surgeon may perform one or more following spinal decompression procedure. So I'm going to read few definitions and I will show you some of the images of these procedures so that you will have an understanding of how these pressures or these nerve compressions are treated. Okay, so the first one that is listed in the CPT manual is corpectomy. Now, corpectomy involves removal of a part or removal of the part of all the vertebral body along with the adjacent intervertebral disc. All right, so in the image also again you can see a part of the vertebral body or entire vertebral body will be removed. That's what we call as a corpectomy. All right, next we have facetectomy. So facetectomy involves removal of a part of the facet, and this creates additional space for the nerve root. So you can see over here, let me show you over here, you can see that is your facet, and a part of the facet will be excised. It can be done on one side or on the other side as well. Over here also you can see, in this image also you can see, this is a face, this area is a facet. So that's a facetectomy procedure. And next we have foraminotomy. And foraminotomy enlarges the neural foramen and the opening through which the spinal nerve exits. So by widening this passage, the pressure on the affected nerve root can be relieved. So foraminotomy is done over here. You can see over here as well as here. Okay. Next we have hemilaminectomy. So hemilaminectomy involves removal of a portion of the lamina on the side of the vertebra. So this area is your lamina, and hemilaminectomy, only a part of the lamina will be removed. Next we have laminectomy, where entire lamina will be removed. This entire process will be removed. And then we have laminotomy at end, which involves removing only a portion of the lamina. Okay, only this area will be removed. So by removing all these structure, the pressure that falls on the nerve root reduces, and this is a kind of a decompression procedures. All right. Okay, I hope it's clear, and you can find all these images in your CPT manual as well. These are taken from your CPT manual. Okay. Okay, now that you understand the anatomy of the spine, the concept of the decompression and purpose of arthrodesis, let's take a closer look at one of the most commonly performed lumbar fusion procedure. This is called as transforaminal lumbar interbody fusion. Now, let's start by comparing first two images. First image, you will see a normal healthy spine with well-maintained disc height, intact facet joints, and normal alignment. Now, in the second image over here, you can clearly see a degenerative spine disease, right? And this causes spinal instability, nerve decompression, and chronic pain. So, to treat this condition, surgeon first focus on relieving the pressure on the nerves and creating access to the disc space. So, one of the first step is facetectomy. Okay, first, as you saw in the previous slide, facetectomy, a portion of the facet will be removed. It can be done from one side or other side. Sometimes doctor will go ahead and also remove the lamina, that is known as laminectomy, and also may perform foraminotomy. Okay, so these are all decompression methods. And now once the doctor get access to the disc space, you can see, then they will do a discectomy, which is removal of the disc. So this not only remove the diseased tissue but also further decompress the nerve root and prepares for the space for the fusion. Next comes the interbody cage placement. So cage is typically filled with, it's a device. We will talk about them in the instrumentation part. So this is a device which will be filled with the bone graft. So bone graft can be taken from either patient's own bone, which is autograft, or from synthetic or other bone substitute, or a donor, which is allograft. Okay, so this graft is placed inside this cage, and the purpose of the cage is to restore the height. The cage is placed in the space, in that exact disc space from which the disc has been removed, and this also serves as a scaffold for bone fusion. So the surgeon places a pedicel screw. After that, once the cage is inserted, surgeon will place a screw, and then a rod will be placed. The screw and the rod will be tightened. All right, and over the time, the bone graft placed inside the cage will grow, and it fuses with the upper and lower vertebra into a single solid bone. And this process is what we call the arthrodesis, the process of fusion of the bones, or we call it spinal fusion. All right. Is that clear, coders? The process and entire process, because we are going to code for these procedures in the upcoming slide. Let me know in the chat. Is that clear for you all? So It includes the spinal. We have done the arthrodesis. We have done the spinal instrument. We have used them. We have used a graft. We have used a cage. So all these procedures came together in this particular procedure, in this particular operation or surgery. Okay, I see chat is so silent. Let me know in the chat, coders. Are we good so far? Shall we move on to the coding part? Okay, you can let me know if you have any questions. All right, let me know in the chat. Great. Thank you, Letty, for letting me know. Okay, so now we are moving on to arthrodesis procedure. So arthrodesis procedures are classified based on the approach. So whenever you see an arthrodesis procedure while coding, first thing you have to think is, or first thing you have to identify is the approach. Approach is how a surgeon gets to that region. Okay, so there are three approach. First is the anterior approach over here, where the surgeon accesses the spine through the abdomen or through the front. Okay, anterior is through the front. And then we have posterior. So in posterior, surgeon accesses the spine from the back of the body. He will have to move those some muscles and all. Then he accesses the spine. And third one is a lateral approach, where the surgeon reaches the spine through the flank or the side. So these are the three basic approaches. And the CPT codes you will find in your manual are also classified based on these three approaches. That's why I said when you are coding for a arthrodesis procedure, first identify the approach. Now, in CPT manual, you will find the approach classified as, first one is the anterior or anterior lateral. So anterior means front, anterior lateral means front and side approach. And these are the codes. We'll find first code is 22548, which is used for arthrodesis anterior transoral or extraoral technique. So this is transoral or extraoral. All right. Next, you will find codes 22551, which is the primary code. And this code represents anterior interbody arthrodesis of cervical spine below C2. And this code, the 22551 and 22552, it includes full set of works like the disc preparation, the disc removal, which is discectomy, osteophytectomy, decompression of the spinal cord or the nerve root, interbody fusion. Everything is included in these code series. Okay, remember the code, these procedures we performed in the previous slide. So all these procedures are included in 22551 and 22552. Next, we have 22552 is for each additional interspace, all right, below the C2. And then we have another set of codes, 22554 through 22585. 22554 is for cervical, is this actually represent the anterior interbody arthrodesis of cervical spine with minimal discectomy. So only minimal disc removal is performed in these code sets. And the disc removal is actually performed to prepare the interspace and not for decompression. All right. So that's the main difference between 22551, 22552, and the code series from 22554 through 22585. All right. I hope that is clear. In 22551 and 22552, there will be discectomy, osteophytectomy, decompression, while next series sets of codes, you will have only minimal discectomy. And finally, also we have 22586, which is for arthrodesis, presacral interbody technique. So pay attention to those keywords. All right. Next, the second one, we have lateral extracavitary approach. So this comes from the side. We have only three codes under it. So 22352 is for arthrodesis, lateral extracavitary technique thoracic. You have 22533 for lumbar and 22534 for the thoracic or lumbar each additional vertebral segment. So this is the add-on code. 22552 and 22553 is the base code, and 22534 is the add-on code. And finally, third approach was posterior lateral or lateral transverse process technique. And these codes are they are coded from 20590 to 22634. So let's do a bit of small kind of a chunning. I will show you how these codes are classified. So posterior lateral infusion means fusion is placed along the posterior elements. Now we have code 22590 to 22595, that is for arthrodesis posterior technique. C2 cranio cervical level, C2, then 22595, that is for arthrodesis posterior technique, atlas from C1 to C2. Okay, here comes another group of codes, that is for arthrodesis posterior or posterior lateral technique, single interspace below cervical below C2 segment. Then we have a code for thoracic, lumbar, and then we have code for each additional interspace. Okay, so these groups are for posterior or posterior lateral technique. Then we have 22630 to 22632 for arthrodesis posterior interbody technique, including laminectomy, discectomy to prepare interspace other than for decompression, single interspace lumbar, and then for each additional interspace. So you must recognize the difference between these two codes. That's a technique. So 22600 to 22614 is for posterior or posterior lateral technique, while 22630 to 22632 is just for posterior interbody technique. Okay, so the techniques are different. In posterior interbody technique, you will have the disc removal, and the fusion, actually the graft is actually placed in between in the interspace. Okay, that's why it's called interbody technique. While in posterior or posterior lateral technique, it's not placed inside the interspace, it will be placed outside. Okay, and next we have a third set of group, that is 22633 and 22634. Now this is the interesting part. This is for when arthrodesis is performed by combination of these two techniques. Okay, you can see the combined posterior or posterior lateral technique with posterior interbody technique. So when you have arthrodesis performed at the same interspace or same level in the same session using two techniques, combination of two techniques, the posterior or posterior lateral and posterior interbody technique, then you should use these sets of code. Okay, don't code for separately. Don't code for 22600 and 22630. You should use 22633 instead. Okay, and sorry, it applies only for the lumbar area, not for the cervical area. So it applies only for 22612 and 22630. Okay, all right, I hope it's clear. And let's see how you are doing so far. Let's do some exercise. So this is a kind of a straightforward exercise. You have to pick the correct CPT code based on the arthrodesis technique used. So coders, remember what you have to do: identify the approach first. All right, so let's do this one. First question: what CPT is reported for this procedure? Option A 22556, option B 22532, option C 22610, option D 22630. A patient with thoracic instability undergoes spinal fusion through lateral extracavitary approach T8 to T9, and a minimal disc removal is performed to prepare the interspace for fusion. What CPT code is reported for this procedure? And you got 1 minute. It's a straightforward. You can start typing your answers in the chat. All the best, coders. You are going to rock this one. I'm pretty sure about it. All right, that's time. You can see few answers in the chat about rest of your coders. Go ahead, place your answers. I'll give you a couple more seconds. So great answers so far. All right. So please don't. We are not going to judge you here. So please go ahead and place your answers. Okay, we are here to learn and we are here to support you as well. So go ahead. Don't worry. Even if you get it wrong, if you learn something, that is priceless. All right, so let's review. So first, let's see our inventory, what happened. So there was a patient with thoracic instability who underwent spinal fusion, right? And it was done through lateral extracavitary approach at T9, T8 to T9. Okay, now what is the approach here? It's a spinal fusion procedure. The approach is going to be lateral extracavitary approach, right? So it must be done from the side. And let's look into the codes. Okay, and minimal disc removal was done. So keeping that in mind, 22556 is coding for arthrodesis anterior interbody technique. Now that's not what we are looking at. We are looking at a lateral extracavitary approach. So option A is wrong. 22610 is coding for a posterior or posterior lateral technique. Again, approach is wrong. And we have 22610 that is for arthrodesis, posterior or posterior lateral. I think I read that, or 22630. So anyhow, 22610 and 22630 is coding for a posterior approach, right? We are only looking at a lateral extracavitary. So only option left is option B, that is arthrodesis lateral extracavitary technique, including minimal dissectomy to prepare the interspace thoracic region, right? Okay, so I hope the explanation helped. Let's do another one. A 56-year-old patient presents with cervical radiculopathy and spinal cord compression at C4, C5, C5, C6. A surgeon performs anterior cervical discectomy and fusion, which is ACDF. At each level, surgeon performs discectomy, osteophytectomy, decompression of the spinal cord and nerve roots, and interbody arthrodesis. So I should have read the first answers first. Okay, I'll correct it next time. What CPT codes are reported for arthrodesis? Option A 2254554, 22585. Option B 22551, 22552. Option C 22551 times 2. Option D 22554 times 2. Coders, your time begins now. You've been doing a great job. Put your answers in the chat. All right, time's up, time's up. So great answers once again. Excellent. First thing, what we are going to look, we are looking at approach. What approach was used here? I can see it was anterior cervical discectomy. So it's an anterior approach that was used. All right. I believe there were two levels. You had C4 to C5 and C5 to C6, right? So two interspace are there. And at each level, the surgeon performed discectomy, which is a disc removal, osteophytectomy, and decompression as well, right? Okay, so two CPT codes are only available for us. One is 22554, that is for arthrodesis anterior interbody technique. So technique is same, no issues, right? And the problem with 22554 is that it includes minimal discectomy to prepare the interspace. So it only includes a discectomy, minimal discectomy, while we had discectomy, osteophytectomy, as well as decompression of the spinal cord or nerves, right? So that makes 22554 incorrect. 22551 is coding for arthrodesis anterior interbody technique, and this includes the disc based preparation. There you go, your discectomy, osteophytectomy, and decompression of the spinal cord or nerve roots, right? So the decompression is also included in CPT code 22551 and for below C2. So this 22551 is code for first base code, and then you have to code for additional interspace that would be 22. Yeah, that would be 22552, not 22585. Okay, for C cervical below C2, each additional interspace. So the correct answer is B for the scenario. Good job, good job. Okay, next one. What code is reported? A 22630, 63052, B 22630, C 22612, D 22633. A surgeon performs lumbar posterior interbody fusion at L4 and L5. Laminectomy is performed only to access and prepare disc space for fusion. Of the following, which best describe this encounter, Chorus? Place your answers in the chat. Excellent. I'm really impressed by the way you all are coding these spinal arthrodesis procedures. Great coding, everyone. All right. So here we have a lumbar posterior interbody fusion at L for L5. So posterior interbody is a posterior approach that is used. We had a laminectomy performed as well, and it is done to access and prepare the disc space for fusion, right? That's the only purpose. That was not a decompression here. Okay, so we have 22612 that is coding for arthrodesis posterior or posterior lateral technique. We didn't had a posterior or posterior lateral technique. We had we had a posterior, sorry, we had a posterior technique. But why I would say 22612 is incorrect is that hmm okay. Yes, I got it. So it's not coding for the interbody fusion. There you go. It is not coding for interbody fusion, right? It is just anterior, arthrodesis posterior, posterior lateral techniques. So that's why option C is incorrect. Now option D coding for 22633 is for arthrodesis combined posterior or posterior lateral technique with posterior interbody technique. We had only one technique, by the way, in this one. So option D is also incorrect. Between option B and A coders, let me know. I'm interested to know why would most of you went with option B. Why didn't you select option A? Type your answers in the chat. Quickly, coders. Quickly, let me know. I've got just some more time left. So quickly, let me know. Why you thought like option B is the right one? Why didn't you code for 63052, which is a laminectomy code? Okay, I'll just wait for a few more seconds. Because a laminectomy was also performed right over here. It was done to access and prepare a disk space for fusion. Okay, Great answer. Yes, great answer. Great answer. I can see answers are coming through. Excellent one. So there is a guideline which specifically says that decompression perform on the same vertebral segment and or interspace as posterior lumbar interbody fusion that includes laminectomy, fasectomy, and foraminotomy. Maybe. So there is a condition when you can report them separately using 63052 and 63053. That is when they are specifically used for a decompression. Okay. And the second line is also interesting. Decompression solely to prepare the interspace for fusion is not separately reported. Right? Yes. So in our scenario, laminectomy was just done to access and prepare the disk space, not truly for the decompression. So there was no significant enough decompression procedure performed in order to build them separately. All right, I can see some great answers in the chat. Excellent work. So, does that make sense, coders? Let me know. Are we good? You can let me know in the chat. So, we will move on to the next one, exercise number 4. Okay, I will try to make it. We'll pick up the pace a little bit here. So, you can start answering what codes are reported. I will start the timer. You can start answering what codes are reported. Option A 22633, option 22634, option B 22612, 22630, 22632, option C 22633 times 2, option D 22630, 22632. A transforaminal lumbar interbody fusion is performed at L3 and L4, L3 L4 and L4 L5 with both posterior lateral and posterior interbody fusion at each level of the following which best describe the encounter. Okay. Okay. So first thing to look is the approach. Okay. Whenever you see an arthrodesis procedure, go by the approach. All right. You can see answers are coming. Great. All right. So I will walk you through. You can work on it as well since we are running out of time. I have a few more slides to cover. So I will start explaining. So again, as I said, first thing I'm going to look is approach. We had a transforaminal lumbar interbody fusion done. There were two interspace L3, L4 and L4, L5. And here we had a combination, right? A posterior lateral and posterior interbody fusion. So there's a combination of approach or the technique that was used. And if you remember, I told you the guideline, you have to use the combination code here if you have a combination of technique used. That is arthrodesis combined posterior or posterior lateral technique with posterior interbody technique. That's exactly what happened here. Posterior lateral, we had a posterior lateral and posterior interbody techniques that were used. So the correct codes should be taken from 22633 and 22634. All right. And the correct answer, yeah, I can see in the chat. That is option A. Fabulous. Great job. Great job. Okay. So quickly going through the guidelines which we learned, arthrodesis or fusion may be performed alone or with other procedures. And when the arthrodesis is performed in combination with other definitive procedure like osteotomy, fracture care, corpectomy, or laminectomy, we can use Modify 51. Bone grafts are always reported separately in addition to the arthrodesis procedure. Instrumentation, when performed, is reported separately in addition to the arthrodesis. And this is one thing which you can, yeah, I think you all know this. The add-on arthrodesis code 22585, 22614, and 22632 should not be reported with 51 modifier because they are inherently additional add-on procedures and are exempt from multiple procedure reduction, right? And two surgeons act primary surgeons each reports a distinct work, and a modified 62 is appended with the codes 22548, 22558, and 22585. So you can churn this guideline. And finally, decompression may be reported separately with 63052, 63053 only when performed for a true neural decompression, and it is not separately reported when done only to access or prepare the interspace for fusion. So we also did a scenario on them. Okay, now quickly let me move on to the second topic which I was talking about is the instrumentation. Yes, the instrumentation in the spine surgery refer to the use of hardware like a pedicel screw, rod, hooks or plates that is used to stabilize the spine and support for the fusion. If you remember in the initial slides, I show you the procedure, entire procedure, right? So you saw towards the end we place some screws, rods, and we stabilize that fuse area, right? So that's when you will use these instrument codes. And the instrumentation, the I'm specifically talking about the spinal instrumentation here. The spinal instrumentation codes are classified, or there are mainly two types. One is segmental instrumentation, the other one is non-segmental instrumentation or fixation. So segmental means, over here you can see an image. The segmental means screws are placed at each level of the spine that is a part of fusion. So in simple terms, I can say we will fix the top level, which is a proximal hooks, and then we will fix the bottom level, which is the distal hooks, and at least one of the level in between. So you can see the intermediate hooks. All right. That is what we call a segmental instrumentation, right? And then we have a non-segmental instrumentation. So in a non-segmental instrumentation means screws are placed only at the end of the construct. So the rods are passed over the levels in between, but the middle bones are not directly fixed to the screws. So let's take this example. You can see you will have a connection at the proximal hook and then distal hook. So there is no connection in between. So that is your non-segmental instrumentation. So it's a simple thing to remember, right? Okay. Now, yeah, here I have another image that will also help you to easily understand. This is a segmental instrumentation over here. You can see a lot of connection in between, whereas in non-segmental there is only two connection. Okay. All right, so let's move on to the CPT coding for the spinal instrumentation. They are divided into, or they are classified into two types. One is posterior and the other one is anterior. So in posterior, you have two section again. One is for posterior non-segmental instrumentation. By the way, we have only one code which specifically codes for a non-segmental instrumentation under the classification of posterior instrumentation, and that is 22840. And the remaining one, 22842 to 22844, that is for posterior segmental instrumentation. So you can see how the codes are, or how the code language is. The CPT code 22842 is used when the surgeon fixes 3 to 6 spinal levels with screws and rods. And then you have 22843. This is used when the fixation extends from 7 to 12 level. And then we have 22844, which uses instrumentation spans 13 or more vertebral level. All right, so that's how it's classified. And also you have CPT code 22841, which is used for internal spinal fixation by wiring of spinous process. And then we are looking at the anterior instrumentation codes, that is ranging from 22845 through 847. Again, they are moving up the level based on the number of levels that is fixed. Okay, 2285845 is when the surgeon fixes 2 to 3 levels over here, 2 to 3 levels, vertebral segments, and 22846 is for 4 to 7, 22847 is for 8 or more. And then we have 22848, which is code for pelvic fixation. And important thing to remember, coder, is that with these codes, you cannot assign a 62 modifier. All right. That is a guideline to remember, and that's something you can churn in your manual. Do not report 62 modifier with the instrumentation code 22840 through 22848. Okay. All right, now let's understand the biomechanical device, or commonly called as cages. There's another section for it. So these devices are actually, if you remember the example which I showed, so these devices are placed inside the spine, right? In order to maintain the disc height, restore the alignment, and also help with fusion. So you saw the cage instruments inside which the bone graft were placed and they were inserted into the interspace. So we are talking about those devices. So let's call them cage. So we have three sets of code: 22853. This is used when the cage is placed inside. Okay, first one, 22. Yes, over here, 22853 is used when the cage is placed inside the intervertebral disc space. And this code should be used during the interbody fusion surgery only, right? And then we have next code 22854. This is used when cage, or this is used when cage is placed in a vertebral body defect after the corpectomy procedure. So corpectomy means entire vertebral body will be removed, and then this cage will be inserted. Okay, that's when we use 22854. And finally we have 22859. That is used when cage or structural device is placed but no interbody fusion is performed. So when you have no interbody fusion, you can see over here, without interbody arthrodesis, that's when you use 22859. And once again, do not append 62 modifier to the instrumentation codes. Okay, so under the instrumentation, again, we have one more section of codes that is used for vertebral tethering, vertebral body tethering. So vertebral body tethering codes are from 22836 to 22838. So this is an interesting way, or this is an interesting surgery. This is actually used, or it's called a scoliosis surgery, and that is used, or that uses a flexible code to guide. You can see a flexible code will be used over here, and it is used to guide the spine correction while keeping motion and instead of permanent fusing the bone. So in the arthrodesis, you saw that we had to remove a bone and or remove the segment and then fuse, right? So instead of the fusion or arthrodesis, this sets of codes is used. Instead, there will be no fusion. Okay, they will be used to correct the spinal scoliosis. And again, these are, one thing to note here is that these are the only instrumentation codes in which a 62 modifier is permitted. Okay, and there's a condition as well: two primary surgeons should work together on distinct part of the procedure to assign them. All right, and the final section under instrumentation, these are the codes for reinsertion, removal, and yeah, reinsertion and removal. So guidelines associated with it is that when all instrumentation is removed and new instrumentation is inserted during the same session at the same level, you will report only the insertion codes and not the removal and reinsertion codes. Also, do not report reinsertion and removal procedures in addition to the insertion or new instrumentation codes. All right. I hope the instrumentation part is also clear. And let's quickly do some exercise. How should a surgeon report the instrumentation portion of the procedure? Option A, 22842, 22852. Option B, 22842 only. Option C, 22849 only. Option D, 22849, 22852. A patient presents with or presents for a revision of previously placed spinal construct During the operative session, the surgeon completely removes the old posterior segmental instrumentation, and surgeon then inserts a new posterior segmental instrumentation that spans five vertebral segments, which includes previously instrumented levels. How should the surgeon report the instrumentation portion of this procedure? Quickly, coders, let me know in the chat. You got only a few little time left, so give your best shot quickly. Okay, I can see one answer. Great. We have a Q coder here with us. Okay, coder. So you have to apply a guidelines to solve this one. The guideline I just reviewed in the previous slide. Okay, so here a patient came for the revision of a previously placed spinal construct, which is an instrument, by the way. So the guideline, he removes the old posterior segmental instrumentation, and then he inserts a new posterior segmental instrument, right? So the guidelines stated that only appropriate insertion codes should be reported when previously placed spinal instrumentation is being removed or revised during the same session where new instrumentation is inserted at the levels including all or the part of previously instrumented segments. So if there is a removal and insertion, we will code only for the insertion. Okay, and this was a revision, by the way. Patient came for removing the old and then inserted a new one. So you will only code for the insertion codes, that is 22848. Okay, did the explanation help? So it was just a guideline base. So you can refer the guideline. Only appropriate insertion codes, I will repeat it, should be reported when previously placed spinal instrumentation is being removed. So we had a previously placed instrumentation that was removed here or revised. The revision is exact word which was mentioned in the scenario during the same session where a new instrumentation is inserted at the levels. Again, we had a new instrumentation, that is new posterior segmental instrumentation that was placed at the levels including all or the part of previously placed instruments. And we had at the previously placed instrument level as well. Okay. Okay. Yes, it's an add-on code, by the way. So I just place this one. You cannot assign this as a standalone code. So this scenario was just to check your guideline knowledge. All right. We will not code this alone. I was just given this scenario just to check the guideline knowledge, just which we reviewed. Okay. All right. So I think we will skip this one and quickly move on to the last part. I'll skip this one as well. We had few questions, by the way, and these are the spinal instrumentation guidelines. The final part is the grafting part. So the grafts codes are also classified into two parts. One is for the allograft, the other one is for the autograft. They are straightforward. You have to look after the keywords and then select the correct codes. So the guidelines which you have to remember is that bone grafting procedures are reported separately in addition to the arthrodesis. So whenever there is an arthrodesis and a grafting, you have to report both separately and do not assign 62 modifier to the bone graft. Right? All right, last question for the day, Chorus. I think we can do it. Okay. All right. So the question is, of the following answers, which best describe the procedure? Option A, 63090225558 with a 51 modifier, 22585, 22845, Option B, 63085, 22533, 22585, 51 modifier, 22808 with a 59 modifier. Option C, 22612 times 2, 22808, 22840 with a 51 modifier, 20931. Option D, 63090225558, 22858 with a 51 modifier, 22845 with a 51 modifier, 20931 with a 59 modifier. A 42-year-old male is brought to the hospital after a motor vehicle collision and is diagnosed with an unstable compression fracture of L3 vertebral body. After failed conservative management, surgical intervention is planned. Using an anterior retroperitoneal approach, surgeon performs a corpectomy of L3 to decompress the spinal canal and remove the fractured vertebral fragments. Following decompression, the surgeon performs an anterior lumbar arthrodesis spanning L2 to L4 to stabilize the spine. To maintain the alignment and provide stability, anterior spinal instrumentation is placed across the fused level. A structural allograft is inserted between L2 and L4 to facilitate the fusion. The procedure is completed without complication. All right, coders, you have 2.5 minutes to solve this one. Take your time, and your time begins now. So, no worries if you're late. We have a playback always available for you to review them. Okay, so if you want to go through them again, don't worry at all. And your time begins now. Coders, place your answers in the chat. All right, that is time. Okay, thank you for participating, and thank you for being engaging with us in the chat as well. Okay, I can see answers are coming. Good, great. I will give 10 more seconds for everyone to put the answer in the chat. Okay, give your best answers, no problem. And after that, I will review this. All right, Coda. So let's move along and let's solve this one together. Uh, these are the inventory which we have. We have in diagnosis inventory a compression fracture, procedure inventory. We have a partial corpectomy and anterior lumbar arthrodesis was done. Anterior spinal instrumentation was performed as well. Okay, now the approach is first thing which you have to look. So in CPT code 63085, that's for vertebral corpectomy. And approach here for this procedure, this definitive procedure was transthoracic approach, right? So we had a retroperitoneal approach, not a transthoracic. So that's why I would say option B is wrong. Option C is also incorrect because you see, option 63090 is the code for vertebral corpectomy for retroperitoneal approach. And definitely, there was a definitive procedure performed over here, which is corpectomy. And we have to code them. So option C is not coding for a corpectomy procedure. So that's why I would say option C is incorrect. Between option D and A, let's see the codes. So 22558 is coding for arthrodesis, anterior body, anterior body technique, including minimal discectomy to prepare the interspace, lumbar. So that looks like a good code. And we had a arthrodesis at how many levels or how many interspace from L2 to L4, right? So L2 to L3, you have one interspace. L3 to L4, you have your second interspace. So definitely I have to give an add-on code, and the add-on code would be 228 or 22585. So yes, so 22558 is a base code, and you have to give an add-on code 22585, and that makes option D incorrect. Option D is not coding for the second level. And let's have a look at the remaining codes. We have 22845, which is for, what is 22845? Okay, over here, 22845, that is for anterior instrumentation. 223 vertebral segment. We had two segment, right? Yeah, we had a two segment over here as well. So we have anterior instrumentation as well covered. And then we have 20931, which is for allograft structural for spine surgery only. So a structural allograft was used. That's what I said. Focus on the keywords while picking the codes for the graft. So we had an allograft. That's for spine surgery only, and that makes option A the correct one. All right, coders, how are you all doing? Because from what I see, you all have been rocking in the chat throughout the spine procedures. Sometimes this is a complicated, or sometimes you might feel overwhelmed coding the spinal procedure. But from what I saw, you nailed it. You were nailing the guidelines, putting the answers quickly in the chat. So how did you do, Chorus? Did the session help you to feel more confident? Let me know. And remember always, the mastery doesn't happen in one session. It happens with consistent learning, repetition, and right support. So if you feel like you want to watch the playback, it's always available in our AMCI YouTube channel. What you have to do is you have to go to our AMCI channel. There is a section which is called the playlist. Go over there. You can find all the videos that is related to CPT guideline mastery inside them. So I will move this video as well soon. to that playlist. And finally, coders, I would request you all to please do take a moment to fill out that survey form which I've shared in the chat. You can let us know which topics you are looking forward to. We will be doing next session. We'll be doing the cardiovascular, some topics from the cardiovascular. So we have already covered few topics in cardiovascular. You can review or you can view them in the playlist. And if you have anything new or any new topics that bothers you or you want to us to discuss, please let us know. You can mention them in the chat as well. Sorry, in the not in the chat, in the survey form which we have placed in the chat. And we'll try to pick them. So as I said, we are listening to you. We are carefully listening to you, and whenever you request for some sessions, we are providing them. Okay, so please do take a moment. It takes less than a minute, and let us know your thought. That's all I ask. Okay, and one more important thing, don't forget, or if you enjoyed our video, please smash that like button, subscribe to our channel, and share with this content with someone who need to see it, because that's how we know, through the survey forms and your likes. Okay, number of likes, your comments, everything, that's how we know that you're liking our videos. So please don't forget to hit that like button, subscribe to our AMCA channel. We have a lot of great contents coming way, and share it to someone you think need this. Okay. All right, coders. So we will meet next Friday with a new topic. Hopefully, you will some of you will let us know any topic you want to hear about from the cardiovascular chapter, and we'll pick them. Okay. So till then, stay safe, keep coding, have a great weekend ahead, and we'll see you all next week. Take care. Thank you, team. Thank you, Miss Moose. Thank you, Miss Catherine, for helping and supporting the coders throughout in the chat. Okay, bye, coders.
4,000 exam passers and free classes at AMCI. Learn to coach straight from home or on the road at